Good evening, everyone. Welcome again. This week's teaching session delivered by our FRCS mentor group. Just to introduce ourselves, we have, I'm Firas, I'll be facilitating the session tonight. We have Shwan, he'll be the presenter. And we have Ramesh, who will be supporting him. We also have Fuad and David from the mentor group. Shwan is going to present very important and very hard topic. Very few people are there to talk about it. So Shwan is kindly prepared. It is about nerve, anatomy, physiology, and neurophysiology, and how to draw a nerve. So there'll be two parts of this presentation. First part about how to draw a nerve and how to discuss and talk about action potential. And after a small break, there will be another discussion about neuromuscular junction and the function of muscle cell. Please use the chat option to ask any questions. Next to your name, you will find the raise hand option also to raise your hand. And please stay alert. We'll randomly pick one of the candidates to answer questions that Shwan feel are appropriate. So over to Shwan without any further delays. Thanks.
Thank you for us. First of all, congratulations. I know you guys are not about to sit the exam again, but congratulations to the guys who have passed. And to anyone who hasn't passed, stick with us. We will help you. Don't worry along those lines. The first thing to say about nerves is everyone panics about these things. There's nothing to worry about. So if you're asked to draw a nerve, the first thing to do is to draw 3 circles. So just draw 3 quick circles. 1, 2, 3. And then draw lines connecting these circles. Sorry. And again, my lack of artistry is showing that up very nicely. So what you then have is, you say this is a nerve, this is a cross-section of the nerve. What you then get is your nerve covered by an epineurium. Your middle layer is which is a bunch of nerve cells, which is a bunch of nerve fibers, which are bonded together by peri. And finally, your endoneurium, which then has individual nerve cell fibers. Okay, axons together. Now, the reason why that's important is it's part of the understanding that this is the cross sections. But understanding that the blood supply to these nerve cells are actually twofold. There's extrinsic and intrinsic blood supply. The extrinsic blood supply enters through the epi and sorry, let me undo that. Through the epi and then attaches onto a peri arteriole group, which essentially is just on the outside of the peri. Okay. That's the extrinsic blood supply. The intrinsic blood supply vertically drops down through that and then bathes individual nerve cells, nerve axons with blood supply, individual fascicles of the nerves, okay? So what that means then is when you mobilize nerve, like when you're doing an ulnar nerve transfer, what you're doing, ulnar nerve release and transfer, what you're doing is you're devascularizing that nerve by disconnecting it from its extrinsic blood supply. However, the intrinsic blood supply is still preserved because there's communication all the way along the endoneurium. What that clinical application is, if you're doing your transfer, make sure you don't put tension on your nerve, because if you put a little bit of tension on the nerve, you're actually stopping the blood supply. And the more tension you do, the more likelihood you lose the blood supply to the intrinsic blood supply. You're going to lose the extrinsic anyway because you've mobilized it away from its vessels. However, the communication of the intrinsic is still preserved. So this is an important clinical aspect of this knowledge. Okay, that's when you're asked to draw a nerve cross-section. Now, we're going to, again, excuse the very bad drawing, but this is not an artistic competition. We're going to draw a nerve cell. This is what they're going to ask me to do. So what I do is just draw a large, very poorly drawn circle, and then draw an axon down the line with dendrites coming in this way. Draw your nuclei, say that it's a nucleated cell. What is a nerve cell? What is nerve? It's a highly specialized connective tissue, which is a form of communication and from the nerve to the rest of the body, from the brain to the rest of the body. It's quite important to show that there is a mound here, this area, the axon mound, okay? Then what you need to do is demonstrate that you understand that there are Schwann cells which create myelin sheaths, and refer to these as your nodes of Ranvier between the myelin sheaths. Okay, why is that important? Because the myelin sheaths essentially are insulation around the nerve cell, the nerve axon. They prevent the communication of sodium and potassium moving through to the axon in that area. So it's like a big copper wire with a conduction plastic on it, with small little gaps into it. This is important because this is what the term that you need to use is saltary conduction. Saltary conduction. A couple of other things you need to talk about when you're drawing this is to say that the intracellular, the sodium is in low concentration, while potassium is high concentration. Extracellular, potassium is low concentration, sodium is high concentration. How do you remember that? Well, what's your normal blood tests? Your potassium is a low number, 6, while your sodium is 122. That's blood, that's outside your cells. This is important because this is all about nerve conduction. So I then describe the conduction in this situation. I say that there's synapses on dendrites where nerve stimuli come in or other stimuli come in. For example, stretch receptors in muscle as part of your reflex pathway. So if your stimuli are coming in, they hit the dendrite, they then go through the cell body, and the cell body has an effect on the action potential that does come. The action potential can dissipate or magnify in the cell body depending on the function of that cell body. Once it reaches the mound, it then reaches an all or nothing threshold. If it passes that threshold, it will continue to conduct down. So we'll drop this diagram for now and come back to action potentials. We talked about thresholds. You need to then draw, at this point, you need to draw an action potential graph. Everyone has a tendency to do this. I think that's just setting you up for having to explain something a little bit more difficult to explain by making your graph a little bit more difficult to do. So what I would suggest instead is putting your y-axis much higher. The reason why is you can then demonstrate straight away that this axis is a negative. You start off in your negative area and you can move up to a positive of 30. So you draw on your y-axis, make sure you do show that you're talking about milliseconds. Okay, because all of this is quite important in describing how the action potential comes down. Remember we talked about threshold, so you can get multiple stimuli hitting the dendrites, multiple action potentials trying to reach the mound of the axon. If you get a small hit, which doesn't reach threshold, it'll go back down again. If you get multiple hits or one large hit, it eventually reaches a threshold, which is usually around -55. And once that happens, the action potential propagates. Now, what you then get is about 1 millisecond of action potential, and then you go down to hyper minus level. And this area is what we call the refractory period from here to about here is the refractory period. So what's happening in this situation? Everyone knows how to draw this diagram, but they can't explain what is happening. So once action potential reaches the mound, once it reaches threshold, sodium channels, or voltage-gated sodium channels start to open. These sodium channels allow diffusion of sodium across the osmolarity gradient into the cell. So you've got high concentration sodium outside the body, outside the cell body. Now you're getting the sodium diffusing into the axon because the voltage gate is open. Once that voltage gate is open, it stays open only for 1 millisecond. So as much sodium gets in as quickly as it can. This creates a second voltage gated channel, the potassium one, to open. This is again a diffusion type channel. This allows potassium to move from a low concentrated area to a high concentrated area. So if I just change the colors of the diagram, we're just going to show you what's happening with the sodium gated channel is about here, doing the same thing, and they're closing at this point. Potassium gated channels are here, and they only start to open here and then close down here. Once we reach the subthreshold level where we've got a 2 negative charge, the action potential, the charge within the axon is negative, then the ATP pump, sodium potassium exchange pump, which is ATP controlled, is then activated. This redresses the balance until the balances come back to normal again, with sodium leaving the cell in exchange for potassium coming into the cell. There can be no activation of this nerve cell. So that prevents multiple rapid signals coming down that axon. Therefore, it's in motor, for example, it actually prevents hyperstimuli of the motor units. Okay. Why is this important to understand in terms of our clinical applications? So first of all, we talked about saltatory conduction. There's another form of conduction without myelin sheath where you can get just the diffuse conduction as there's one group of sodium channels open, the next one's open. That's a slower conduction than the saltatory conduction. So if you lose your Schwann cells, if you lose your myelin sheath, you lose the ability to saltatory conduction, so your reflexes are slower, your ability to respond motor and so on, much slower. But more important, in our everyday applications, we use local anesthetic. We use it for reblock, we give local anesthetic topically, we give it into arthroplasty interventions. The effect, the way the local anesthetic works, it's a sodium channel blocker. It binds reversibly to the sodium channels. So once they're opened, the voltage once the voltage gated sodium channels are opened, the local anesthetic binds to them and prevents them from closing. By preventing them from closing, they prevent the whole process from occurring. They block the channel completely. So therefore, no sodium can get in. Therefore, no action potential can propagate. Does that make sense? That's the clinical application there. If we talk about the pathway down the axon, you can appreciate that the voltage gated channels are not energy dependent. However, the sodium potassium pump is energy dependent, ATP dependent. And ATP requires oxygenation. Again, this is the reason why it's important to know the blood supply and to protect the blood supply when you're doing a nerve transfer. Okay. For us, anyone got any questions so far?
I haven't received any particular questions yet, Shwan, but if you feel you have a question to ask, let me know.
So can I ask anyone can tell me about why it's so important to know about the threshold for conduction? Is there any clinical application to that threshold?
Anyone wants to answer? I will pick someone randomly, so excuse me, guys. I will pick Faiz. I know he's a good guy. Faiz, you want to answer Shwan's question, please?
Trying to work the mic. No.
Yes, we can hear you, Faiz. Yeah.
Okay. Sorry. So I missed the last part there of what the question. I'm not very sure, to be honest.
Okay, so
What's
during my presentation, I mentioned that there's a threshold level that's required for propagation of the action potential. Is there? Can you think of a reason as to why that has clinical applications in our everyday life?
I think it's because when the threshold is reached, the action potential propagates, and I think the strength doesn't matter. If it's not reached,
Okay.
then
So, for example, I mentioned earlier on that your reflex pathway is action potential control, but also specifically how many sensors activate and send the signal up to the spinal cord. So, if you're doing a patellar knee reflex on a patient who you get if you press on your patellar now, press lightly on it, what happens is you don't get a quads kickback. You don't get a patellar reflex, a knee reflex, correct? Pressing lightly. Hit really hard, really fast. That creates hyper stimuli of multiple receptors, which are being actioned by quick movement, but also by high force. They send the signal up. There's no time for the signal to go up to the brain to say, actually, I know that this is what's happening. Don't give a kickback. Instead, they go through the spinal cord and come straight down because enough stimuli, enough sensors have received and hit the dendrite. So if I draw that cell again for you, just very quickly. So if this dendrite, and this dendrite all get hit and they send their stimuli into the mound here, you're more likely to get a propagation there rather than just one dendrite sending a signal across. Does that make sense? So if you get one sensory signal coming here, hitting onto that dendrite with a single pressure, not hard, fast on your patellar tendon, you're not going to reach threshold, but you're getting multiple hits. Therefore, this cell is propagating multiple action potentials, which eventually all congregate in the mound, which reaches threshold. They collect together, they summate together, and then you get a reflex. Then you get a signal sent to your quads from there directly.
Okay, I have a question, Shwan. I think a common exam question when these issues are discussed is the gate theory. Would you be able to, candidates have been asked about the gate theory in this scenario. I don't know if there's something.
The gate theory in reference to the voltage gates?
In reference to pain, is that what you're asking for us?
Yeah.
In reference to pain, I'm not familiar, but I do know that regional sympathetic dystrophy is the loss of impedance, or partly due to the loss of impedance of feedback in process. So what's happening is you're getting multiple firing of your action potentials, your multiple sensory feed into your nerves. The nerves are not getting that gated theory. So this is your cell body. If your nerves, remember I said some of the cell bodies inhibit action potential transmission depending on what their function is, while others multiply it. So for example, if you're getting a single sensory associated with pain, that is more likely to go through to the axon transmit from the dendrite across the cell body into the axon for cells that are designed to have reflexes to pain, while cells that are not designed to stop you from going into tetany will try to decrease the number of, it will be inhibitory to the action potential crossing the cell body. So you need actually a lot more stimuli before the action potential will cross the cell body itself.
Yeah, thank you.
Okay, guys. So that's a good question. David, do you want to answer that one? Polio.
What about polio? I was just thinking that's quite a common question, particularly in post-polio syndrome.
Yeah, I'm sorry, I haven't thought about that. So do you have the answer for that?
No, I was just remembering you had a very good explanation of it previously. That's why I was thinking about it. That's a popular question.
At the moment, it's gone from my mind, but I
All
know
right.
we'll
think about it for next time.
What is the question, David?
Post-polio syndrome with regards to action potential. Why do you get this? So polio, in terms of the virus, you have the acute infection when they're children, and then when they're older, they have post-polio syndrome, which is a result of reduced muscle neuromuscular junction. I can't quite remember off the top of my head, but there's a popular question, and it's quite commonly a good. Sorry, I'm a bit too close.
No, you're fine.
You're fine.
I know it's coming to me. Look, I'll get it. I do remember.
Yeah, I think that's a very good question, David. I think post-polio scenarios can come in exam. Very rare these days, obviously, but they can come particularly in the clinical part of the exam.
Yeah.
You could be faced with, had polio many years ago, from the 40s or 50s. And it's important to know that post-polio present with muscle weakness, paralysis, myalgia, and fatigue. But the actual, neurophysiological reason behind it is something that we need to look into.
Yes.
Thank you. Okay.
No worries. I know the answer. I got the answer somewhere. I'll use it when I do my webinar as a little bit at the end. Don't worry.
That would be great. Thanks, David. Carry on, Shwan.
Sorry, I just remembered what post-polio's connection to nerves. So, in a patient who suffers polio, they lose a lot of their nerves initially in their first hit of their disease. However, those patients often, the ones that do well post initial attack of polio, that seem to be walking well and so on, they have no problems. What's happening with those is they get hit at a young age. So when those nerves that supply the muscles, let's say, for example, your quadriceps muscles, the nerves that are supplying your quadriceps muscles, as they get injured in polio, other nerves grow their dendrites. So if I draw this picture to you, this is actually quite a good point. Thank you very much, David. So if in terms of a motor unit, what is the definition of motor unit? It is a single nerve and all the muscles innervated by that single motor nerve. So when a motor unit is taken out by polio, the surviving motor units try to recruit the muscles that were lost to the die-off of the first nerve. So what you get is an extra axon growing off and creating further neuromuscular junction to recruit these muscles. Sorry, I'm trying to draw a muscle here. So to recruit these different fascicles. So if you've got multiple axons, each one is recruiting a different myofascicle. So what then happens is, as you've got bigger and bigger motor units, a single injury to a single motor unit, a single die-off, as the cells get fatigued and tired over time, as the cells die off with aging, the effect is much more pronounced at a younger age of these patients, because for one nerve to get hit in post-polio syndrome, what's really happening is the cell is dying off, and a large percentage of the muscle in the quadriceps muscle, for example, are dying off. That entire motor unit is not working. So that's the progressive weakness that you see in a patient who's developed post-polio syndrome. Does that make sense?
Yes, yeah, it does. Thank you, Shwan. Now, Shwan, we have another 5 minutes to go.
Yeah. So I think if there's no immediate questions, we'll leave this and we'll go on to neuromuscular junction and how the action potential conducts across.
Yeah, I think we'll have a small break. We have a few minutes, everyone. If anyone has a question, let me know. We will pass it on to members of the faculty to see if we can have any answer to your questions. Or if Shwan have any questions, we can put it through. No, there don't seem to be any questions at the moment. So, Ramesh, would you like to add anything to Shwan's talk about the nerve structure and physiology?
I think it was a very sort of comprehensive, concise and comprehensive.
Yeah.
I think it was pretty good. The only thing I want to ask is, when you mentioned refractive period, is that period just after the action potential where it hyperpolarizes? Or is it the whole thing?
So once the sodium channels are activated, they can't be reactivated for 2 milliseconds from that moment on. So if you look at the refractive period, it's actually over 2 milliseconds. Unfortunately, we always draw our action potential to cut off before the 2 milliseconds. So my advice is draw your thing wide so you don't have to explain that it's 2 milliseconds.
Okay, that's a good point. Yeah, thanks.
Okay, excellent, excellent. Thank you. Good question. Good questions are as important as good answers. Okay, guys, so we will have a small break, a 5 minutes break for people to stretch their legs, and we will restart again in 5 minutes with another block. We're talking about more about action potential, how it propagates through the neuromuscular junction and through to the muscle cells. A very important exam question and topic, and very important to understand well. It's easy to score high if you understand this concept. The examiners will be very impressed. So I'll end this meeting, guys, and I will see you again in 5 minutes. I'll post another link again. No, it's not too late. It's not too late, Fuad.
Sorry, I just missed the last part because I had a call, because people have passed the exams, so there are phone calls coming. So regarding the questions of the physiology, one of the common questions is what happens to the nerve when it is transected. So I think this is something which can be asked from any one of the candidates, and they can prepare, because that's written quite nicely in one of the books. But that is a common question they can ask actually, and what happens proximally and what happens distally, and what happens in different areas, and how it that can be a clinical scenario that you are operating, and then suddenly you cut the nerve, then what will happen?
We will do that. We will do that at the end of the next session, as a hot topics, hot seat session, and you'll be the examiner for it. Okay, so stay with us.
Okay.